diagnosis, treatment and rehabilitation of people suffering from hearing loss and balance issues, as well as people who are suffering from impacted wax or infectious discharge in the ear canal. This procedure here is of a client who has attended with bilateral occluding earwax. So I'm just starting off with the left ear. You can see the ear canal is quite narrow, a lot of cilia, hair at the entrance, slightly obscuring the view, but I'm still able to visualize a lot of the wax. The wax in his left ear is what I call a clay type of wax. It's very difficult to remove using suction because it can block the suction probe. In addition, when you use an ear hook or a Jobson horn, you just saw me using an ear hook, it just slices through the wax, and sometimes with a Jobson horn you may get some of the lateral piece of the wax, but you can inadvertently then compress and it's going to really impact some of the wax on the base of the ear canal, making it more difficult. So with this type of wax, I always try using some softening drops. I use some olive oil spray here just to bind this wax together, enabling me to get a suction grip, and the oil itself also helps to unclog the suction probe if that does get blocked. The wax is quite lodged, it's near the entrance here, but the wax itself extends all the way throughout the ear canal to the eardrum. So the average length of the human ear canal is between approximately 2.5 to 3 centimeters. And in this case as well, the ear canal itself is almost engulfed, enveloped the wax. It's almost kind of trapping you in. It kind of closes upon itself near the entrance. So it is quite tricky trying to wriggle this wax out, and there's a few hairs there that are matted. So I tried with suction and it wasn't really getting, although it wasn't blocking the suction probe, because it was lodged, it wasn't extracting. So I decided to go in with a Jobson horn, and you can see the Jobson horn is slicing through the wax. So I did get this piece out, but it's actually compressed the rest of the wax against the canal wall. So what I'm doing now is just trying to get on top of that and in behind. You do have to be careful when you're using instruments like an ear hook or a Jobson horn when you go deep in the ear, because you just don't know the client's anatomy of his ear canal. It could be that they've got a sudden bend or twist in the ear canal, and when you insert the instrument through the wax, you're making contact with that canal wall, which can be very uncomfortable. So what I've done here, I've resorted back to the Zollner suction probe, and the medial wax is a bit more, it's not as sticky, it's a bit firmer, so I am able to get a bit more of a suction grip. You can see it's a bit drier compared to the wax that was more lateral near the entrance. And again, I'm just obtaining a suction grip. I'm delicately trying to wriggle this wax. So I normally do that by making concentric circular motions, and slowly but surely this wax is coming out. The ear canal itself is also quite dry. When it is dry, you do get a bit more friction when you're trying to remove the wax. You can see we're nearly there now, I believe. I'm just now trying to get a suction grip superiorly, because I can feel during the procedure that it's lodged near the top. As I've brought the wax more medial, I'm now able to use a Jobson horn, because it's less risk of me causing any injury or trauma to the client, because this wax is more lateral, where the ear canal is made up of cartilage, and it's far less uncomfortable for the client when you make contact with the cartilage aspect of the ear canal as opposed to the bony part. You can see there I've just got another segment out, and there's a gap just at the top there through the hairs, and I'm just going to be inserting that Jobson horn in there, trying to get in behind the wax and slowly lever this wax out, which I've managed to do there. You can see quite a lot of skin adhesions on that wax. That was the white patches around the edge, the periphery of the wax, which is adhered to the ear canal wall. The eardrum's nice and healthy there. This is the client's second ear. In this ear, the wax is literally almost kind of visible at the ear canal entrance. So it's trying to migrate outwards, but it just hasn't quite managed to do so. And I feel with this client in his right ear especially, the ear canal is a bit more narrow and twisty near the entrance. It's a bit drier, the consistency of the earwax compared to the client's left ear. So I'm just trying to use a Jobson horn, trying to get in behind the wax on the posterior canal wall to kind of lever it out. And now I've gone superiorly at the top of the ear canal. There's a bit of a gap there, so I've managed just to insert the Jobson horn there and slowly but surely levering this wax out. Again, there's a lot of cilia there. It's slightly obscuring the view, but I'm still able to visualize the wax, and it's kind of really safe for me to continue. If there was a lot of cilia there, what I would typically do is get some crocodile forceps and pluck those hairs out. Can be slightly uncomfortable for the client, but more often than not, they do tolerate it. The problem with trimming those hairs, if you trim those, they could just fly loose in the ears, kind of matting more against the wax, making it more tricky to remove. Again, I'm just using a Jobson horn. I'm able to go posteriorly there. You can see again at the base of the ear canal, there is quite a few skin adhesions, and as this wax is being extracted, this skin is peeling off the ear canal, causing a bit of blistering. Not much really we can do with that. It's not uncomfortable for the client, and it's quite normal when you perform earwax to get a bit of bruising, a bit of blistering. The ear canal is very sensitive, very delicate, and it's not always the case that it bruises or blisters when you make direct contact. Sometimes as you remove the wax, as the skin adhesions peel away, it's that itself that's causing the blistering and bruising. The wax here is a bit more lodged. We're more kind of midpoint centre of the ear canal. It's quite dry, loads of hair there. I'm just trying to loosen it, so I'm just trying to get a suction grip, lifting it, and I think I'm going to go in again with this suction probe, am I? Let's have a look. No, so I've decided now to use a St. Bart's heel hook. There's just enough gap at the top for me to insert that hook behind the wax, allowing me to gently lever and maneuver this wax forward. It is quite impacted. You can see I'm trying to put a lot of pressure there as I'm trying to extract this wax. So again, there's a bit of a gap at the top. So a lot of these videos, I'm narrating over them a few days later. So for me, I can't remember exactly what I did at the time. So in a way, I'm visualizing the video myself and anticipating what I should be doing, and which is quite useful because when I review my videos, I always learn new things. We're never too old to learn. That's part of being any professional. You review your work, you analyze it, and you kind of ask yourself what you can do better. So for me, watching these videos back is a great learning tool. And again, I'm using the ear hook there, just trying to get this wax through that narrow entrance. I'm trying to get, once I get in behind the wax, I'm putting a bit of pressure when I'm levering this, just to extract this from the entrance. And I've got the majority of the wax there. You can see there's a coating of dead skin there, and it's very dry and crusty. So I'm now using a fine engorged attached to a standard Zollner suction probe. I find actually at this point it's not a fine engorge, it's the normal standard Zollner suction probe, and I'm just trying to lift this larger piece of wax. You could sometimes use a crocodile forceps, but with forceps, with this type of dead skin, although it's dry near the entrance, it's a lot more damp and softer, more medially. So I find with a crocodile forceps, you may be able to get the crusty bit of wax out, but you're not, the remaining skin, more medial near the eardrum, it's still present. I always try to like getting skin off in one go. It's just a lot easier sort of tearing it into little pieces. So to help me with that, I've just instilled some sodium bicarbonate earwax drops. I find that works better with skin than olive oil. And now I've attached a fine engorge to the standard Zollner suction probe. And the reason for that is that with skin, it can clarinet. You've probably heard me in my previous videos. When you suction skin, it can flap and flap very violently, and we call that clarinetting. And clarinetting can emit a very loud, uncomfortable, high frequency squeal, which can not only be almost deafening for the clinical ear care specialist, but more so for the client, because we're in the ear canal very adjacent to the eardrum. So you were just seeing there, I'm just trying to gently loosen this dead skin across the canal wall. I'm now on the posterior canal wall, just gently lifting that. As the skin gets closer to the eardrum, there's a lot more tension, and you may not be able to see it kind of by just watching the video, but when you're performing the procedure, you can feel that skin is a lot more stubborn. That skin, does it warrant removal? I think with that amount of skin, yes, I do, because that skin, there's large flaps there, and if it's windy or if the client's chewing or kind of talking, they may feel that skin flapping in the ear canal. It won't contribute to any reduction in hearing, but it may just be a bit itchy for the clients. So when there's a large piece of skin like this, I do like to try and remove it. It's not always possible. Skin is very difficult. You can imagine when you've got kind of wrinkled fingers and a bit of dry skin there and you're trying to peel it. It is a bit uncomfortable, and it is quite quite tough and stubborn. So I've lifted the majority of the skin now, and I'm just on the superior. So when I say superior, I mean at the top. Inferior means at the bottom, so facing the ground. Anterior means facing towards the midline, the nose, in this case for the right ear, and the posterior canal wall is the back part of the ear canal, facing away from the nose. I've got the majority of the skin there. It's just some at the base, so inferiorly. You've got the crusty bit that I've got contact with the fine end. Beyond that, it's a bit more loose and damp dead skin. I'm just trying to wriggle. The client is, you can feel me in the ear canal, but it's comfortable. It goes without saying, if you've got skin in your ear and someone's really deep in your ear canal with an instrument, they are going to feel that. But as long as it's comfortable, that's the main thing. And in this particular procedure, the client is completely comfortable throughout. If the client at any stage expressed any discomfort, we would have stopped immediately. But the client was tolerating the procedure very well indeed, which enabled me to continue. Bit more skin there. I don't think I was able to remove all the skin, but I've got the big flap off there. You can see a few remnants of skin. That's fine. That's not going to cause any symptoms to the client. It's not going to be itchy or irritable when the client talks, or if there's any wind in the ear. And that's the eardrum. So the eardrum slightly dull, no light reflex. Typically, when you've got a very healthy eardrum, when we examine the eardrum using an endoscope or an otoscope, or indeed even an operating microscope, you get a reflection of the light that we use to illuminate the ear canal off the eardrum, and we call that a light reflex. And a light reflex typically indicates a very healthy and normal and functioning eardrum. Thank you for watching, guys. You would have seen 3 still images there of the wax I removed from different angles. I hope you enjoyed that video, and if this is the first time you've been watching one of my videos, please do feel to subscribe onto my YouTube channel. When doing so, please also select the bell icon so you get notified as and when I upload new videos. And if you're watching this on Facebook, please do like, share, comment and follow my Facebook page.